Dr. Jha is the head of medical physics in radiation oncology and a professor of molecular medicine at Taussig Cancer Center in Cleveland, Ohio. She's an APM fellow and is awarded for distinguished service and contribution to the ASTRO's educational programs. Dr. Jha has been directly involved in clinical implementation of IMRT and IGRT, two major advancements in radiation oncology in the past 2 decades, and she published over 140 peer-reviewed articles and 9 book chapters on these topics. Dr. Jha was the chair of several APM task group reports, and her current research is focused on automation in radiation oncology. Dr. Jha, it is a pleasure to have you with us today. Thank you.
Thank you. Thank you very much for such a wonderful introduction. Let me share my screen. Just please let me know whether you can see my screen here. I'm still, let's see. Share. I hope you can see my screen right now.
Yes.
Yeah, good afternoon, everyone. Thank you for inviting me to give this talk. And I know that you have very distinguished speakers in this chapter meeting, and my talk will be very low key and then more practical, I hope. So the title of my talk is Using Automation to Improve Treatment Planning. I have one disclosure that I received a research grant from Advanced Oncotherapy in London. So this is a picture of a Cleveland Clinic main campus. You can see that in front of this big, beautiful building, there is very modest, humble 4-story building. This is the origin of a Cleveland Clinic. This year, we celebrate 100 years birthday of a Cleveland Clinic. 100 years later, Cleveland Clinic has this massive medical centers across the 6 blocks. This 7-story building is our new cancer center. In 2017, we just moved into this new cancer center. So if you have an opportunity to visit Cleveland, please contact me and I'd be happy to give you a quick tour about the Cleveland Clinic. This is a list of the learning objectives in my talk. So first, we were going to discuss about the importance of process control in radiation therapy. And I'm going to propose that we need to change paradigm from catching error to preventing errors in treatment planning. I know many of us as a physicist, we check charge, we're trying to catch an error. We need to change our design to really preventing error to be occurred or included in the treatment planning process at the first place. Then I'd like to share with you about using automation in treatment planning process to improve plan quality and then standardize our planning process. First, let's discuss about this, that the recent, about a few years ago, Radiation Oncology Incident Learning System, ROYOS, reported that 30% of reported events occurred during the process of treatment planning and the pre-treatment review and verification. Another publication showed that treatment preparation to be the most common point of the error origination. As a medical physicist, we cannot sitting still reading all those reports. Seems like despite we are working very hard trying to catching errors, but we still let the error to go through our fingertips. So of course, medical physicists working very hard to do initial chart checking. We're also trying to emphasize the importance of a pre-treatment chart review by the therapist and also physician plan review and the peer review. All those are very important. However, how effective are we? This important publication published by Eric Ford when he was at Johns Hopkins and also along with WashU group. In this publication, they show the quality control qualification. Basically, they measure the value of everything we do in radiation therapy. How effective are we? This is a figure they showed here that they listed many things we do, such as physics chart checking, weekly chart checking, therapist chart checking, using the checklist, using the epidosimetry, physician peer review, chart review. We do using image, using check SSDs and doing timeout. And also we, most importantly, we do iMultiQA. Look at all the tasks listed here, that majority of them is less than 50% effective. Perhaps most important is our physics initial chart checking. It is reached to about 63% effectiveness. Well, how do we make our effectiveness improved? So in this paper, they emphasize one check is not enough. Nobody's perfect. So you can see here is based on the severity. With the low severity items, we need a minimum have 4 checks to check each items we checked. And for high severity, it means very important. If you have those points is unchecked or slips through your fingers, it will cause more the incident to have a high severity. That means we have to have 7 checks. Despite we have 7 checks, you can see it's a saturation. No matter how many checks we do, it's still at 95% effectiveness. That means we cannot catch every errors in the treatment plan. Furthermore, you can see the details here that for all the common things we do, it's listed on the right side. We only achieve the 97% effectiveness. If we only do physics initial chart checking, it's only 63%. If we added portal dosimetries, that effectiveness improved. And you can see if we added timeout, then we improved a little bit. And then later, if we added physician doing chart checking, it's improved to 93%, and so on and so forth. You can see later, we're pretty much saturated at 97%. So therefore, even in the AAPM, we're working very hard. Eric Ford leading the effort of TG275, trying to propose a strategy for effectiveness of a physics plan peer review, a plan check and a peer review. That I hope some of you already read this task report. I also leading another group in parallel with 275 to try to develop more of a practical guideline about the plan and chart review. So this is a figure included in 275 report. You can see here that treatment plan related items is listed in a green dot here. This is more than 100 items listed here. This is a frequency use of the check. And then x-axis is RPM. RPM standing for risk priority number. That is a product of severity, occurrence, and the detectability. So you can see many items, the green items here in the treatment planning has important RPM or high RPM numbers. So as a physicist, if we do manual check for all those items, that somehow you will feel that somehow you will miss certain items. So subsequently, recent publication from University of Maryland, they did manual check. They recorded the number. So if you follow TG275 full list, that it will spend about 100 minutes to 163 minutes to finish one plan review. And then they also follow MPPG 11 list. This is around from 29 minutes to 1 hour. I'm glad to see this because during the design of our MPPG 11, we estimate each chart should be in average takes about 30 minutes to complete. But obviously it depends on the complexity. Some chart is more complex than the others. But nevertheless, if we do everything in manual, it will take us quite a bit of time. So I don't know whether any one of you read a book called Toyota Way. Reading this book, I find it's very inspiring. In this book, Toyota just to have a very basic principles. I think we can learn from Toyota because they make very nice car. So the principle is right process will produce right result. So that we need to focus on the process instead of mitigating the planning. We should have the the error prevented in the planning process. So another thing is what we are going to say, it is not just physicists alone. We need to have a team. So I always said that we have a basketball team in radiation therapy. Those are 5 members here: physician, nurse, dosimetrist, physicist, and the therapist. We perfectly form a basketball team. So among those tasks, we need to share responsibility among all our team members. We cannot take everything into our only one shoulder. So we, in MPPG 11, we just make it all order in a sequential order from simulation order to simulation. So physician need to provide us a clear, comprehensive simulation order. Then the simulation can proceed it without any hiccups. And then physician will finish their prescription and the contour of normal tissues and the critical structure. Obviously, planner dosimetrists can assist them for certain easy critical structures. And then planning. Then the physicists will be participating on the pre-treatment QA. Therapists should be also participate on the pre-treatment QA. It's another layer. So for MPPG 11, we laid out all those tables in the bottom row here that we think everything need to be starting from simulation order. We want the therapist to check it, make sure the simulation order is comprehensive and complete. And then also the planner should also working with the radiation oncologist to do another check, such as whether the contour make sense, is the logic correct? And then before they passing their plan to the physicist, we were recommending the planner should do their consistent check. They should run some kind of checklist to make sure those plans follow the standards, local standard. Then obviously physicists and therapists should do their part of the check. So the paradigm I think we should switch is from catching error to minimize error. How do we do that? One thing we need to do using automation. Automation in planning, automation in plan check. Automation in planning is quite a challenge because I will discuss about that. That's why I call this instead automation is using advanced planning tool. So we know that many planning error is created or occurred is because our planner is under tremendous time pressure. And we also need to use automation to do plan consistent check. Another way to minimize error is to standardize. Standardization of our nomenclature and also communication pathways, such as simulation instructions, planning instructions. Finally, we need to standardize plan report. So I'm going to go over those, all those listed things here in the next few half hours of talk. So let's switch gears about advanced planning tool. So you can say it's automation planning tool. I called it advanced is because I think advanced automation in planning is very challenging. The challenge part is due to this objective function. This objective function is not just gradient descending, because we certainly want to find the global minimum, because our objective function could be easily trapped us into this local minimum. That's why treatment planner often needed to do iterative planning. Inverse planning did not make anything automation for us. When you put into plan objectives into the inverse planning, the plan come out is not necessarily what you want. So here is the problem. I think it is mostly, maybe I am wrong, but I mostly kind of a blame on the gradient search engine in the inverse planning. So gradient-based search engine could not find a unique solution for each plan. That is why planner today still needed to do iterative planning. You need to constantly changing your plan objectives, creating rings, and also continue optimize. So I like cooking. I cook Chinese food. I always said this kind of process is more like Chinese cooking, that I wish we can have a more of like American style cooking. You have all the ingredients, you put into the plate and it's stuck in the oven, and then 1 hour later, the dish is ready. For Chinese cooking style, that means you have to be really constantly adjust the temperature, adding ingredients, taste it, and then, you know, this is the way I'm cooking every day. I know it is very time consuming. Another way is that those objectives are not very well defined for each plan. So even though we have knowledge-based planning, and then later there's a commercial product, so-called the Plan IQ, mitigating the problem, but it's still not a solution, automated solution for us, because the plan objective keep changing. It's really a moving target. Another problem is that, as I said, because of gradient search engine, that we need to do more progressive optimization. So there is some commercial planning systems that can do auto planning. It's not really a good term. It is more of they can automatically running optimization, which I'm going to touch upon. And then lastly, there's so many trade-offs in the planning. How do you balance out spare normal tissue versus cover target? So then there's more of a so-called using multi-criteria optimization. MCO is also implemented in some commercial treatment planning system. So first, let's look at the knowledge-based planning. This is very popular. And then this is a slide, a courtesy from my friend Jackie Wu. So based on the previous plan from our database, that we can, based on the distance, the target and the normal tissue distance, volume, or dose distance, we can extract the features. And then we can make those models into your institution specific. Training the model, and then with the knowledge-based planning, you can use this model to provide planning guidance for new patient. Also, you can use the model as a quality assurance. So there's many publications about effectiveness of using knowledge-based planning. Another advanced planning tool is implemented in a Pinnacle treatment planning system. I know not many people using it, but this automatic planning system is really a progressive planning. They automatically including many loops of the optimization instead of manually doing it. Also, another thing is into this auto planning, they can create surrounding structures and then tuning contours automatically, even progressively adding planning objectives. For example, this is a slide showing here that initially the planner only added about 7 planning objectives. It's very small font here, but this auto planning will automatically generating additional 2 or 3 times more the planner added objective. So the objective is progressive, is gradually lower the dose, the tolerance dose to the critical structure, and then also balance out whether the target coverage is compromised. So MCO is implemented in the race station. I'm sure some of you are using it, that you certainly need to require a set of those constraints. That means it cannot be compromised or violated. Then typically those constraints could be like maximum dose to the spinal cord or brainstem. But then you also have a set of those objectives you're willing to compromise. This is a negotiation allowed. Then this system will generate about many plans to give you the trade-offs. So the user certainly can log into some satisfied trade-offs, but it takes some time to continue navigating in this kind of negotiation. In my view, the ideal treatment planning system should have all 3 of those tools for us. You should have a knowledge-based planning to give us DVH predictions, no longer one size fitting all kind of those constraints. Even for prostate, the separation between the rectum and the prostate is patient dependent. We need, based on those separations, to give us patient specific those volume histograms. We need auto planning, which means we should allow to automatically to do multiple loops optimization, continue change our dose objectives. Some physicists in our group, they already can program this, program it. And then we are in auto planning on top of the auto planning, because in our current auto planning is a 6 loop of optimization. Why stop at 6 loop? Why can we just do 12? You can continue doing this. And obviously we need a MCO to provide trade-off solutions. There's promises and also pitfalls in those advanced tools. We use the auto planning in our clinic for over 7 years. We already see that we have improved the plan quality and efficiency and also consistency. However, using those advanced planning tool can only preventing so-called bad plan, which is a C-graded plan. Using advanced planning tool can give us B+ or A- graded plan. And also we learned the plan created from the advanced planning tool are not necessarily clinically acceptable. Those symmetrists and planners still need to further optimize to achieve the clinical goals. The reason behind of this pitfall is because that our current inverse planning based on objectives are lacking of a spatial information. So this is a hypothetical diagram drawing. So let's say the red is the prostate and the blue is the dose distribution achieved. So for example, if from the plan objective point of view, these two plans perhaps are equivalent because they're not looking at any spatial information. However, for prostate, if you have a cold spot in the middle of the prostate, this is not good. Obviously, I'm not talking about urethral sparing right now. I'm just assuming that if we want to cover the entire prostate with a uniform dose. However, if you have a little bit underdose in the edge, perhaps this is preferred than this the cold spot in the middle. So let me give you some clinical examples that about what we did, a comparison of advanced planning tool versus clinical situation, a clinical plan or manual plan. So this is examples that we compare a partial brain tumor that with a clinical plan using AP, advanced auto planning, KVP planning, and the MCO. If you don't look at those distribution, just look at the endpoint here. Obviously, we're setting the dose coverage to the target is the same. But if you just look at endpoint here, the goal is to getting maximum dose less than to the brainstem, less than 60 gray, chiasm less than 56. If you look at all those advanced tool planning, looks like they're better than clinical plan. But then if you go back to look at it carefully about the dose distributions, let's pay attention for the MCO plan. The MCO plan retrieved the lowest dose to the chiasm, but they have quite a bit of hotspot inside of a PTV. And also this 60 gray line is not as conformal. And also 51 gray line is not as conformal. So you look at the clinical plan. By the way, this is a two dose levels. So the yellow is the 60 gray, the blue is receive 51 gray. It's a SIB plan. It's a simultaneous integration planning. So you can see among those plans, the clinical plan on this one is still the best because they have the smallest hotspot. Despite the critical structure is a little bit higher than the other advanced planning tool, if I presenting these 4 plans to clinician, I think our clinician will choose this plan. Especially you can see the MCO plan will be a crossover the middle. Let's look at another example. This is a spine SBRT that we compare of 4 different planning approach. So this is a clinical plan. This one's very simple that we want to have the maximum dose to the spinal cord less than 14 gray. You can see that a clinical plan achieved this goal, AP plan did not. KVP plan did not, but the MCO plan make even better. So on this one, the MCO plan achieved the most conformality. On this case, the KVP plan, because the knowledge-based planning, we don't have a model specifically for SBRT. So the plan still produce very uniform dose distribution. Therefore, it's not as conformal as what we wanted. This is another example we compare for prostate plus pelvic lymph nodes cases. So on this one, we want concurrently treating prostate, PTV to 70 gray, and also lymph nodes to 54.4 gray in 28 fraction. So again, with the same target coverage, if you look at the endpoint here for the rectum and the bladder, it's very obvious that AP or knowledge-based planning and the MCO plan is far better than the clinical plan. But if you look at the dose distribution here, you can see that AP and the knowledge plan truly, it is very conformal, and also the better sparing on the bladder. And the clinical plan in the lymph nodes area is not as conformal, and the bladder sparing is not as good. For MCO plan, even though the other endpoint for the rectum and the bladder is good, but the dose conformality to the lymph nodes is not as good. Especially they have this weird, 35 gray kind of poaching out. I'm sure with further optimization, this problem can be eliminated. My point here is that, this is why I want to illustrate advanced planning or auto planning is challenge, because you still need to have a little bit manual tuning on top of those advanced planning tools. So as I mentioned, that all the problem we have is, first of all, we use DVH. It is really degenerate dose prediction. We need a three-dimensional dose distribution. So I find out there is commercial product from Sun Nuclear that they can predict it 3D distributions. It's really, I think this is what we need. So it's called Plan IQ. That can be used as, used as a guidance for the planning, or you can use this tool for plan quality control. So I'm going to give you a little bit detail about how this product worked. First, they need to import the CT data set and contour the critical structure. And then they, based on the benchmark dose grade, they can predict it. They use the high gradient dose spread function and the low dose grade spread function to predict it of the dose distribution. After that, because even though they can predict 3D dose distributions, but they still cannot import automatically into our inverse planning. Then, based on this dose prediction, they also predicted so-called the predicted DVHs. So here is what their dose prediction look like. This is exactly what we need, is to have a 3D benchmark dose prediction. And then this is what this is a tumor contour and the normal structures. So this is what we get, the prediction dose. But then they degenerate into so-called feasibility DVHs based on the difficulty of the plan. So it depends on whether you want to use what F score you want. So it's a program rate. Using this diagram to show if it's yellow, it's more of like is easy achieve, or green is easy achieve, yellow is moderate difficult, if it's red it is difficult to achieve. So we tested this Plan IQ on 20 SBRT pancreatic cancer patient. We look at the critical structure based on their Plan IQ driven replanning. I'm going to show you some of the examples. Here is Plan IQ driven replanning. So basically we run the Plan IQ, they give us a predicted dose form histogram. We just directly plug in of this dose form histogram as our plan objective and run the optimization. And then you can see there is a duodenum here that we were able to achieve some kind of sparing. For our clinical plan, this duodenum is not pushing hard enough. And then you can see from those form histogram, this is the dark gray curve here showed us that under Plan IQ driven replanning, we were able to push this DVH further into the very difficult region. But this way is our clinical plan. That means there's room for a clinical plan to push harder. The key is, how do we keep pushing? That, we only have a limited time. That is why I'm very advocating for using those advanced planning tools to improve our efficiency, and then we can keep pushing, keep optimize our plans. So let me switch gears to talking about how to using automation on the plan integrity check. So we published a paper about processing consistent, the plan consistent check, that we use the automation to run those consistent check. We also emphasize using standard format plan documentation, standard nomenclature, which is tumor volume and normal structure. We also even emphasize even beam name need to be standardized, automated. And also the beam treatment order should be standardized. Especially nowadays with oligomatch treatment, we have our plan complexity has been increased tremendously. We're often treating sometimes treating 3 to 5 lesions. How do we make sure it's standardized? So in our institution, we make sure we always treat it from left to right, sup to inf. And also the prescription name need to be standardized as well. So in our automation, we automatically name the prescription name with atomic locations and the total prescription dose, so that it is there for everybody to check. Even look at a name, you will know this plan is planned for what kind of dose. Finally, we want everybody to use checklist and also to run this automatic plan check. Everybody means those symmetrists, when they finish, during the planning, they should run this automatic check. They can run this check before they start optimization. They also must run this check after they finish plan. So this has become a forced action. We find this is much more useful. So all the detail of how to use automatic plan integrity check is published in this paper if you want to know the details. So in this figure, we compare with many other automation plan consistent check. You can see that we compared about whether this program can create a standard plan report, whether this program is integrated with the TPS system, whether it's used by the planner, whether this is a forced function, and then whether the program also generates a report or used on the check the plan and the chart both. So forced function from our point of view is important. You can see that physicists already created many of those plan integrity check, but it is not a forced function used by planner. So it is that you have a back and forth. The planner create an error, you find it, then you go back to ask them to correcting it. So we think it's much more efficient to let the planner directly to using this program to check it and to eliminate the errors that produced during the planning process. We also emphasize that we need to have a standard plan document format. I know some of them even said this is not important. If we have shared database, there is no need to create a plan report, or we should create a very simplified plan report. I have a debate with Dr. Auch in the JACMP. My view is plan report is important. Create a plan report is as if you're doing, is very important a quality assurance process. This is more like you're doing a proofreading. So if you're writing a manuscript, and then when you finish writing, you just go direct to publication, you will know there's some mistakes always in your manuscript. At least it's in my view. And then, so editing and improving it, proofread is very important. So at Cleveland Clinic, we make sure we use a program to make sure every plan follows this standard format. So basically we mandate the order should be followed. So it's very similar, very simple. The first thing is plan summary report, detail, the parameter detail, the plan detail, parameter details, and the dose distribution. So those distribution, we also created some scripting, automatically divide the PTV into 8 axial slices in the coronal view and also sagittal view. And we automatically also including all the critical structures in the DDH. This one is our idiosyncrasy at the Cleveland Clinic. We ask planner will always look at the isocenter location and then measure the table vertical. For this one, we want a planner to automatically think whether this plan potentially have collision, because isocenter location and the table vertical will give you a common sense whether this plan will have a collision. And then for 3D plan, obviously we need including the block shape. And then we also want the planner to look at the beam direction view. This is again once they look at the isocenter and then measure the table vertical, directly going to the beam direction view, they will remind them potentially whether there's a collision. And also lastly, we also want them to run this EPIC program and then look at the report. If the report tells them there's potential warning warning message, they need to address it. And then plan scorecard is more for plan quality check and control. So this is a script that we developed into our Pinnacle treatment planning system. It's a detailed for 3D plan and IMRT plan. So the planner just going here to click on each buttons to automatically go through the plan quality check and then automatically generating a plan report. And then this is not that hard to do. So let me go to the details. So because obviously there's so many items listed here and it's very small font. The first 3 button here, it is trying to rename the plan into change the status. The plan, the final status, we always call it approved. They will automatically change the beam name into follow our local convention and then generate setup beams in 4 different directions and also name the prescription, follow the plan total dose. The middle button is ask our planner to run this EPIC program to make sure they didn't find any mistakes, which I'm going to talk to you about what is contained in our EPIC program. And then lastly, it is a few buttons here. They need to generate a standard plan report. And obviously, because we used recording verify system and planning system are not shared with the same database, then we need to do this function to exporting DICOM into the different systems. So here is a few examples in our standard report. For example, we ask the plan always go to recording. What is your the origin marked in the sim? This is important to check for our physicists because they need to check what is origin initially reported from our simulation. I recently read a paper that I found this is also another major mistakes reported to the Royals systems. And we also ask our planner to revisit what is the isocenter location if it's different from the origin marked on the sim. And then we ask them to review this beam direction. If this plan isocenter is so lateral, perhaps we like to see this beam, the VMAT is using the partial arc. Here is that we're using our program automatically divided PTV into, it should be the 8 axial cut. So in order to save some time, I just captured on 4. Likewise, one click, you will display your tumor dose distribution into 8 sagittal view and a coronal view. And then lastly is our scorecard. We have developed about 100 of those scorecards. So each planner is supposed to using appropriate scorecard to make sure this is meeting our clinical needs. So let's talk about our automatic plan integrity check. This is over the years we developed. The item getting increased. Initially it was 20 some items. Now it's probably approaching 40 items. every those items is what we find is the mistakes made by the planners. So for example, here is the beam name, do not follow our convention. Now with automation, this mistake is pretty much disappeared. We also want to make sure all the beams associated with the same isocenter had same prescription and also are in the same treatment machine names. So those are, for some of you, you have a multiple different machine, they're not exchangeable. This is important. And we also have this little table put into our plan integrity check is again, check collisions, not just what I just described, manually, the visualization, but we do provide the numbers. It depends on the lateral shift of the isocenter and also table vertical. So we will provide a warning. If the table vertical is more than 25 cm, this is based on our measurement, then we will provide a warning, say, check collision. Do you using full arc VMAT plan? So another important part we have, I'm not going to go for the details about everything we do, but it is many things we included is all the mistakes that we find later in our physics check. So all those errors is now dosimetrists can discover themselves. Another thing we added very important in our practice seems like presence of a bolus is use the bolus is a frequent mistakes that the therapist overlook at a bolus. So now we ask our dosimetrists to put a bolus in the 3 different locations. They must put a bolus in the prescription. They must put bolus in the planning instructions, patient setup. They also add a bolus, including sickness, in the beam names. So let's look at the effectiveness of our process. So we look at it over the years about how do we reduce our plan error. We categorize plan error into 5 different categories. So one category 5 is least important. It's more of like bookkeeping. Category 4 is clinical interruption. That means this kind of error, you have to be resolved before patient come. And the clinical flow impediment, that means you're causing therapists some confusion. When they set up patient, if the message is wrong, they have to stop and then investigating. Category 2 is near miss, but those near miss can be catched by the safety net such as IGRT. Or for example, bolus is we put into here. If you're missing bolus for 1 day, it's really it is unfortunate. It is still an incident in our eye, but we make it as category 2 mistakes. Category 1 mistake is if the prescription dose is not correctly planned, such as mostly is a fraction dose. So this is 6 years that we look at our plan error. That we implementing our EPIC program in 2014. It is really out of necessity because, at the beginning, we have about 70 total errors in 5 different categories. You can see it here. And in 2014, we introduced EPIC program run by the dosimetrist or planner. Dosimetrists at the very beginning, they don't feel they have to using it. There's no forced function. In 2015, we made it as forced function that they must run this EPIC plan consistent check before they put a plan document for physicists to check it. Then we find that the plan mistake has been dramatically reduced. And then in 2016, our adaptation becomes so much better. Then our plan error dramatically reduced by 1/3. And then in 2017, since we moved to a new cancer center, we switched to all different treatment machines. From compared to our previous, it's not all. So basically we switched to all TrueBeam. Previously we have all 3 vendor machine. Now we switched to TrueBeam and we decide to insert table in our plan. And then because this a little bit changed, in order to insert a table, that we changed our threshold for external, causing the SSD reported wrong in our treatment plan, which causing so much of those category 4 and 3 errors. And then later we identified that it is plan automatically reported SSD causing so much errors. Then we change our threshold, we further reduce the error. So here in summary, that we have about 272 planning parameter error was reported in our quality check program in 2013 to 2018. And then after we enforce this EPIC check, that our planning error has reduced from 3.4% to 1.5%. Most importantly, the category 1, the category 2 error has been significantly reduced from 0.6% before EPIC to 0.1% after we implementing EPIC. So I'd like to just quickly summarize that I think the plan process control is very important part of quality control. We need to change our thinking paradigm from catching error to preventing error. And obviously, automation in planning process is important tool for us to preventing error. And then we need also using automation tool to improve plan quality and then standardize our planning process. Finally, I'd like to acknowledge our many physicists in making our program and also making our improvement in our program. And also I'd like to thank our department chairman for his support of medical physics to using automation in our treatment planning and then integrity check. Thank you very much.
Thank you very much, Dr. Shah, for an excellent talk. This is indeed a very hot topic. In the latest years, there are many talks and publications highlighting the importance of standardization and automation. You already mentioned about challenges and pitfalls when using automation for treatment planning. Could you please elaborate a little bit more?
So, we certainly always wanted to have automation, but as I said, the gradient search engine, which is used exclusively in every treatment planning system, why they use gradient search is because of speed. That all days you can do similar annealing. Perhaps similar annealing is the better method to do inverse planning, but similar annealing takes so long for planning to do round optimization. That's why all the vendors did not implementing simulated annealing. They're using a simple, quick gradient search engine, which is based on the descending. But our objective curve, as I showed, is really have a multiple minimums. So what we want is to find a global minimum. That is why automation on treatment planning, even though every physicist hope there is one, but it's dosimetrists find again. At the very beginning, when we're implementing auto-plan, dosimetrists was so worried that their job will be replaced by this auto-planning. And then now they learn, well, after auto-planning, I can continue optimize. So auto-planning now in our dosimetrists is very popular. They will run the auto-planning, and then on top of it, they continue optimize to make the plan even better.
Okay, thank you again. Yulia, do you have a question on chat?
There is a question on chat. Someone asked, can you speak to the challenge of checking clinical logic in planning? For example, if the physician's prescription is outside an expected range for a given diagnosis?
That's a very good question. So this is very good questions, very sharp questions. I want to say clinical logic for us, for dosimetrists right now, we told them to check clinical logic is more like ITV should be smaller than bigger than GTV. ITV should be smaller than PTV, this kind of logic. Prescription, boy, it's everywhere. Prescription is a moving target. I just give you an example. For us, we do long SBRT. We have so many different prescriptions. It could be 30 gray, 1 fraction. It could be 50 gray in 5 fraction. It could be 48 gray in 4 fraction. It could be 54 gray in 3 fraction. Those are the standards, right? So I think that the prescription, that's why in MPPG 11, we emphasize prescription still is in the shoulder of our physician. We, as a physicist or dosimetrist, we can, based on our knowledge, to ask them, say, hey, this is outside our norm. Are you sure? If the physician said, yes, this is what I want to do, I would suggest that we leave to physician.
Yes, I think that we all face similar challenges trying to question prescriptions. And, you know, I think that we all use similar approaches to solve this problem. I have a question about using automated treatment plans. I am just curious, do you suggest to use additional QA for the systems employing automation? Or are we just relying on MRT QA, which is kind of debatable now if we should go away from this?
Yeah, I don't think, you know, you can see that Eric's paper, IMRT QA effectiveness for plan quality is very low. And also IMRT QA is always last minute. So I believe automation is only a tool for a planner. Ultimately, the plan quality is still in the planner's hand. And then that's why what we did for automation is to check obvious mistakes. It's obvious mistakes. You can see that, okay, could be also planner in the rush. They just put a beam in the wrong isocenter. Those kind of obvious mistakes. But if it's still the details, is the critical structure being contoured correctly? And then, so we're using scorecard is also to make sure that certain critical structures overlooked. But if there's ever, now with oligomats we're treating everywhere, the critical structures, there's no standard. It's hard, you know, if you do prostate, we know bladder and the rectum is a critical structure. Now, if you're treating oligomats, it could be in anywhere. It could be in the abdomen, then all of a sudden, it could be, you know, the stomach is a critical structure, or large ball, small ball is a critical structure. So it is that we still need a planner and then physicists to learn all the clinical knowledge to add it of those things. I don't think automation will replace physicists. I don't think automation will replace dosimetrists.
Yeah, very good point. I'm trying to see if others have questions. There is nothing in the chat, but if anyone has questions, please raise your hand or put a question in the chat. You also mentioned that you know, you described the tool that you developed, and very interesting results, how you characterize the success of this tool. Obviously, to develop these tools, there is a big effort and only large institutions can do this. Do you think there are there is an effort to actually develop something available for smaller clinics, maybe something commercial that can be used in place of this?
Yeah, I realize, I did know that there is a commercial product. So so I'm not here to just advocating for this product, but I heard, for example, Red Formation, they create a clear check for the Eclipse planning system, of course, causing some money. And we also trying to, because I'm using Pinnacle, then we also trying to see whether the Philips is interested to provide this tool for other users. And then the one thing for us, we were able to develop those tools on the fly, is whenever you find mistakes, you can just add the item, and you don't have to waiting for purchasing any product. We think those kind of flexibility is important. So I understand every physicist is really, especially in the small centers, your clinical load is so heavy. So that's why we like to see, in Cleveland Clinic, that all those tools developed mostly at the main campus. Then we were able to disseminating it to about 10 other regional centers they can using it.
Okay, thank you again. We will receive shortly an invite to join a breakout room. Dr. Shah will join the breakout session also to continue the discussion with attendees interested in treatment planning automation. And the main session will continue with the young investigators' oral presentations. Martina, please take over.